Good morning, everyone. Welcome to today's episode of PYA's Healthcare Regulatory Roundup webinar series. Today's topic is Spring into 2027, CMS proposed rules and payment policy updates for providers. PYA is happy to present today's webinar on this important topic. I would like to introduce our presenters, Kathy Reep and Corinne Leslie.
Thanks, Jennifer. And Corinne, I'm really excited to present with you today. I think I think you presented on an outpatient webinar in the past with Marty and I, so I'm really excited that we are now sharing on this one. As we talk about the various rules that have been released or proposed rules that have been released, it was definitely an onslaught over the last couple of weeks. We have the inpatient proposed rule, along with that one published in the same context was the long-term acute care rule, skilled nursing, inpatient psych, inpatient rehab, and bringing up the end would be the hospice rule. We do know that the proposed rules related to the physician fee schedule and hospital outpatient services are sitting at the Office of Management and Budget and would be expected to be out later in the summer. But for that, let's go ahead and get started and kick off with the inpatient rule. We're going to walk through these, talk about key provisions within the rules, and then hopefully have a little bit of dialogue between the two of us on these various items. Because the inpatient and long-term care rules came out later than the others, comments on the first two rules that we're going to cover are not due until June 9th. However, we're almost the end of this week. We will be looking at May 1st, so the time frame for commenting on these rules is going to be over with very quickly. So, as I always do, I focus on the updates. I look at the money side of this, and I just want you to know that when we start looking at the update, we are again not getting the level of update that I think hospitals expect or would hope to have. They have indicated an overall market basket increase of 3.2%, but they are reducing from that a productivity adjustment, so that they are proposing an overall increase in the base rate of 2.4%. In 2026, we received a 2.6% increase. So they are not, they are basically saying that the projected increase for this year will be less than it was last year. And we know last year was not as what we really expected or hoped to have. They're maintaining the wage index, the labor-related share of the wage index at the current levels. We did take a reduction for those hospitals with a wage index greater than 1. There was a reduction in that last year, but now they are maintaining at that new 66% rate. And statutorily, those hospitals with a wage index equal to or less than 1 are at 62%. So it would take congressional action in order for that to be changed. Capital is projected to increase by about 3.1% from the current $524 to $545. We're seeing an increase, and I think a significant increase, in the outlier threshold. A 28% jump in the outlier threshold, going from the current $40,397 to $51,704. Problem here is by that large of a jump, $11,000 jump practically, what we're looking at is it will be harder for a claim to become an outlier because you're going to have to have your costs exceed the payment rate for a particular DRG plus that threshold amount before it is calculated and considered for outlier payment. So this will impact the actual number of outliers that will be paid in 2027 if it's followed through with the final rule. Uncompensated care, they're looking at about a 3.3% decrease from fiscal year 2026, a rate of about $7.6 billion. Again, last year we did get a slight bump, although they had proposed a reduction. So recognize that it might not, this is a proposed rule. We need to wait for more current data before we actually have the total impacts. New technology is going to result in about $464 million in additional payments under the Medicare program. But when we take into consideration the shifts in the wage index, disproportionate share and uncompensated care payments, outliers, DRG reclassifications, all of those things that go into the outpatient, setting the inpatient rates. I'm sorry, I said outpatient, but setting the inpatient rates. The increase that we're going to see, rather than a 2.4% based upon what's proposed, the actual calculations take us to about a 1.2% increase if we look at the actual dollar amounts comparing one year to the next. So the actual dollar increase is more like 1.2%, which is definitely not a good increase for the new year. You can see on this slide that it separates the proposed rates based upon those with a wage index greater than 1 or those equal or less than. That's table 1A versus 1B. And Corinne will talk a little bit later about quality requirements, but recognize that those dollars are actually going to be lower if you are not if you either do not submit your quality data or are not a meaningful user of electronic health information. So this gives you an idea of the actual dollar amounts on the rates. One thing that was a surprise, I guess I would say, in the new rule is CJR for all. So I think you might remember the comprehensive care for joint replacement model that was in place for a number of years. I think when we started, we had about 800 hospitals that were participating in CJR. When CJR ended, there were a little less than 300, or right about 300 hospitals participating. CMS has attributed the CJR program to over $100 million in savings during the time of that program. Therefore, they have said, we're going to make it mandatory for everyone. So now we are looking at CJR-X as a new model that will be required as of October 1, 2027, this new model moving forward. You would basically, as the hospital, you would be taking financial accountability for hip, knee, and ankle replacements. That ankle replacement is a new addition to this. It will cover the initial surgery, your hospital stay, 90 days post discharge or post service, because this will apply to both inpatient and outpatient services that are provided. CMS is projecting their savings at a minimum of 2% because there will be a discount factor applied for CMS moving forward. So expect that there is automatically expected to be savings of at least that amount. As I mentioned, that this is going to be a mandatory model. However, it will not apply to team hospitals until 2031 when team ends. It will not apply to hospitals in Maryland because of their all-payer system. And those hospitals with fewer than 31 lower extremity joint replacement episodes in the baseline period also will not be subject to this. But other than those exclusions, this program will apply to all hospitals that are paid under the inpatient prospective payment system or the outpatient prospective payment system. So recognize this could be significant change for you, and recognize that if it follows suit for where we were with team, you're going to be getting your data from CMS, and then you're going to have a limited period of time to actually get your network and your relationships established before this would be effective in October of next year. We will expect to see a final rule on this late summer. So again, It's something to start looking at in terms of operationalizing this new model. Again, mandatory for all other than team hospitals, and that will only be until 31 hospitals in Maryland and those that are low volume. The episodes of care under the team model are going to be your major joint replacement or reattachment of lower extremity with major complications and comorbidities, major joint replacement or reattachment of lower extremity without MCCs, and a hip replacement with principal diagnosis of hip fracture. Also on the inpatient side, your hip replacement with a principal diagnosis of hip fracture without MCC. And then on the outpatient side, total knee arthroplasty and total hip arthroplasty. So those will be the DRGs and APCs that are going to be looked at under this program. Finally, when we look at the CJRX program, we're going to have quality measures that come into play. We've listed them for you on the slide. We're looking at the hospital level risk standardization complication rate, hospital visits within 7 days of a hospital outpatient department surgery, your HCAHPS patient satisfaction survey, your outpatient and ambulatory surgical CAP survey, again, patient satisfaction, and your hospital level total knee, total hip, or your total knee, total hip patient reported outcome performance measure. So again, we're going to be monitoring these particular quality measures as a part of the CJRX program. And along with the addition of the CJRX program and the quality measures associated with that, CMS has, as usual, addressed additional quality measures. So I'm going to turn it over to Bryn to address the quality reporting program.
All right, thank you, Kathy. I appreciate that. So I'm going to cover some possible inpatient quality reporting programs and some changes that have occurred. There are some interesting things that I have seen in here as I read through the proposed rules. So we'll go through these and see how these kind of pan out. So first things that's occurring is that there's some addition of 3 new measures. There's quality of care of patients with diabetes and tracking of post-op thrombosis that is not present on admission. Those are 2 measures that are being added for EQMs. The other that I found interesting and that I saw come up a couple of times within the proposed rule is the advanced care planning ECQM. Specifically, the measure is going to be utilizing EHR data to determine the number of adult inpatients that have a documented either care preference or have had the ACP discussion at discharge, with the hope and the goal is that organizations are aligning with the patient's preferences as far as their advanced care planning is determined. I have noticed that advanced care planning shows up in other places within the proposed rules, so we'll cover them there as well. CMS is also proposing to reintroduce the 5 modified 30-day mortality measures for acute myocardial infarction, heart failure, pneumonia, COPD, and CABG surgery procedures into the hospital IQR program for fiscal year 2028 and through 20 for the payment determination. And then those same measures will then transition to the hospital value-based program beginning fiscal year of 2032. What's interesting, though, is that these 5 measures, when they were previously adopted by the hospital IQR program and the hospital value-based purchasing program, they only included Medicare fee-for-service beneficiaries in the measures. What's being proposed in this new rule is what we've kind of seen the shift from the fee-for-service to more of the risk adjustment and Medicare Advantage. And since the initial adoption of these measures, the percentage of Medicare Advantage beneficiaries has actually increased. I believe previously it was approximately 35% of the Medicare population. Now that has increased to approximately somewhere between 45 to 50% of the Medicare population has a Medicare Advantage plan. And so what's happening with the IQR program is that they are expanding the measure to include the Medicare Advantage population. They are also shortening the performance period from 3 years to 2 years. And then they're improving the risk adjustment using the ICD-10 level data. What is, I believe, will be helpful is though that these measures are being reintroduced and modified, they're relying on administrative claims data and encounter data in order to track. So the hope is that there's no added burden to organizations in order to appropriately report these new measures and making sure that they're being tracked appropriately. As with all things, when you make some additions, there are some measures that are being removed. So in 2028, CMS is proposing to remove several measures that hospitals have relied on for years. Those three are the VTE1, the VTE2, and the STK02 measures, mainly because these measures have become very familiar with organizations. And so they've been stable, and most organizations have actually performed fairly well within these measures. And so there's an assumption that they probably don't need to continue to monitor these measures. So those three are being removed. The malnutrition care score, ECQM, was initially adopted in 2023. There were some revisions in 2023 for self-selected reporting. In 2024, there were some revisions made for the fiscal year 2025 rule. And then there were several comments during that time that had actually requested for that specific ECQM to become mandatory. And so what's happening, or what's being proposed in this current ruling, is that the ECQM for malnutrition will now become a mandatory reporting for the next fiscal year. In addition to that, per the proposed rules, hospitals will have an opportunity to continue to self-report on the hospital harm ECQM over the next 2 years of reporting. But what is anticipated to occur is that at some point between calendar year 2027 and 2028, they are going to make the reporting of these measures actually mandatory for hospitals. And then any future measures that are being created or being presented, those will have a period of time where there is some self-selected reporting occurring. And then at some point, I believe that's at 2 years, that self-selecting reporting will become a mandatory reporting. Hospital readmission reduction program, there has been some change to this specific program. So they continue to have the payment reduction of up to 3% to hospitals based on their performance for the 6 procedure measures for readmissions. However, they are considering to add the sepsis hospitalization measure to the readmission category. CMS is proposing to adopt it for fiscal year 2029. So essentially, data that is collected between July 1st of 2025 to June 30th of 2027 would essentially be what is reported for the fiscal year 2029 program. We all know that sepsis is a very popular condition that impacts multiple patients, whether that is an older patient or a younger patient. Sepsis is a high risk diagnosis. And so reporting of it is hoping to improve patient outcomes, improve discharge planning for patients, and making sure that patients are not being readmitted to the hospital because of the quality of care that is being provided through the organization. Just as the hospital IQR program is going to be including Medicare Advantage patients into the calculation, Medicare is also proposing to include Medicare Advantage patients and beneficiaries into the hospital readmission program as well. So the hospital value-based program, which operates under a budget neutral framework, and basically has hospitals that are participating within the program who are getting a reduction by 2% each fiscal year that they are not meeting the requirements. Those funds are then held back and they're redistributed to the hospitals that are doing well. As I had stated before, the 5 measures that you see on the slide are going to start within the hospital IQR program, and then they are going to be removed from the hospital IQR program, and they will be utilized within the value-based purchasing programs starting a fiscal year 2032. The anticipation is, again, that they will include Medicare fee-for-service patients, but also Medicare Advantage patients into the calculation for these value-based purchasing programs. The hospital-acquired condition reduction program, while there's no changes to the program, what was interesting within the proposed rule is that there's this reduction, or there's this calculation of the number of hospitals that are considered to be worst in the performing quartile. And there's about 25% of the hospitals within the United States that are within that 25% quartile, meaning they're performing on the low end when it comes to hospital-acquired conditions. There are no changes to the program, but they are continuing to track how hospitals are doing and where they sit within that quartile to determine if there's going to be a reduction in payment.
And one thing I would add on the hospital-acquired condition program is that is the one program where the reduction is to your entire Medicare payment amount, whereas the others might be a reduction of withhold of 2%, or the readmissions program, which was up to a 3% reduction in the base rate. Under the HAC program, you're looking at your total payment being reduced by 1%, which would be outlier payments, teaching, everything being adjusted. So it is, you really want to avoid that one. You want to avoid all the penalties, but that one is going to have the biggest impact. Within the outpatient rule that, well, actually it wasn't the outpatient rule, within the Consolidated Appropriations Act of 2026, there was a legislation was passed that addressed the requirement for by January of 28 for hospitals to have a national provider identifier for all off-campus provider-based departments, and then also to attest to the fact that they do meet the requirements for provider-based status. Well, we expect to see more on that in the outpatient rule that will come out later this summer. But meanwhile, in this inpatient rule, they did come out with some revisions or proposed clarifications to the requirements related to the requirement under the provider-based regulations that you serve the same population. The main provider and the provider-based department would be serving the same patient population. Currently, that requirement for meeting the same patient population is met by using the term of the criteria of immediate vicinity, that the facility is within the immediate vicinity of the main provider, and that is defined as within 35 miles. If the facility did not meet the 35-mile test, then 75% test is used to show the overlap by patients by zip code, or that 75% of the patients who require services at the off-campus location also receive services at the main provider. What they are proposing is on the outpatient side to limit both options under the 75% test to the inpatient departments only. And if it is outpatient departments only, and if it's an inpatient facility, would be limited to the geographic or the zip code overlap test, so that they are modifying or proposing to modify this particular requirement as it relates to serving the same patient population. As you begin to move forward with wanting to meet the criteria and attest that you do meet the criteria for provider-based, again, currently the attestation is not required, although some facilities have attested to meeting those requirements. But by 2028, they will be required. I urge you to take a look at this and to look at your patient volume on your off-campus versus your on-campus, and make sure that you do serve the same patient population. And you might also want to take a look at whether or not this is a provision that is worth commenting on. Speaking about comments, there are a number of other issues that were included in the inpatient rule that they're either asking for comments on or that were addressed through proposal. The first thing for the transform the episode accountability model or team, there is a request for information in terms of should this program that is now mandatory for a number of hospitals across the country, should it be expanded to ambulatory surgical centers and physician-owned hospitals? So I think particularly if you are participating in team, this might be something that you would want to comment on, particularly the expansion of the program to ASCs. They have expanded the spinal fusion episodes under team, additional services included there. They are addressing DEI, the prohibition on discrimination on the basis of race, color, national origin, sex, age, disability, or religion. Effective October 1 of 26, this would be in graduate medical education programs and nursing and allied health professional programs as well. They are following up with something that they had proposed last year, but they did not do. And this is modifying the formula for nursing and allied health professionals to comply with the regulatory formula. Essentially, the published formula in the manual is different than what is actually calculated on the cost report. So they're syncing these up. And it would ultimately, if enacted, increase payments to providers. There is an RFI related to how to calculate a direct graduate medical education costs and indirect medical education following a hospital merger. And then finally, they are proposing to eliminate the alternative pathway for new technology add-on payments under inpatient and transitional pass-through payments under outpatient, so that there would be a slight modification to these programs moving forward. We should see something in the final rule on this. I think what we will see in the outpatient rule is a reprint of what they finalize in inpatient, but we will see. They might actually do the proposal there as well. So with that on the inpatient rule, recognize that published at the same time, we have the long-term care hospital PPS program. Since these are published together, comments here are due on June 9th. For the rest of this presentation, things will go a lot faster because there's not nearly as much involved in these other proposals. But on long-term acute, they are essentially looking at a proposal of a 2.4% increase to the base payment amount, and an outlier threshold maintaining at the level that they finalized last year, which was $78,936. They had originally last year, I believe, proposed something in the 90,000s. They settled on that 78,936, and they are sticking with that this year. You can see on the slide the actual payment rates in dollars that they are proposing. The $52,177 for those who do submit quality data and are meaningful users, compared to the $51,157 who are not. And I believe that there were also some quality measures involved on that one. No, there were no quality measures on this particular one. So I'll keep going here. Sorry, Corinne. Skilled nursing. Skilled nursing, rehab, psych, hospice were all published prior to the inpatient long-term acute rules. Therefore, comments on the skilled nursing facility rule are due about June 1st, a few days earlier than the inpatient comments. They are proposing an increase in the skilled nursing payment rates of about 2.4%. The payment rate for last year was 3.2. That shouldn't say federal fiscal year 2023. I'm sorry. That should be 2026. This is based upon a market basket increase of 3.2% minus the 0.8% productivity adjustment. They have also included not included a forecast error because it's less than 0.5%. I want you to realize that skilled nursing is the only program that actually has a forecast error. Last year it was 0.6%. What they have done in this particular program is that if we made a mistake with our update in 1 year, we will make up for it in the next. That is not something that they do on inpatient, on psych, rehab, long-term acute, but that is a provision in the skilled nursing program. The labor-related share will increase to 72%. Currently it's at 71.9. That means a little bit more of your payment amount if you're a hospital skilled nursing facility with a wage greater than 1 will be adjusted by labor. And this also applies to those with a wage index less than 1. It would be for all skilled nursing facilities. Quality, Corinne?
Alrighty, thanks, Kathy. So again, some quality measures for skilled nursing facilities that have been added, revised, or recommended to be deleted, but also some revisions that they're making to reporting process. So first and foremost, CMS has indicated that the measures for the COVID vaccine and COVID vaccination QRPs that were previously being reported are no longer necessary. They have served their purpose during the public health emergency, and so they're seeing that they are no longer needed as part of the ongoing SNF QRP program. So they're recommending to delete those. Another interesting thing that I've found and wonder how it will impact skilled nursing facilities is starting fiscal year of 2029, the SNF QRP, CMS is proposing to shorten the submission timeframe from 4.5 months after the end of the quarter. So essentially at the end of a quarter, the SNF organizations have 4.5 months to report their quality reporting measures to CMS. CMS is now proposing that they're going to shorten that time frame by approximately 3 months. The recommendation is that no later than the 15th day of the second month after the end of the quarter is when they would have to report their quality measures. While that is extremely helpful for individuals and organizations that are looking for SNF locations and understanding the quality of that organization, and so that data will be more recent, I do wonder what burden it will put on skilled nursing facilities in reporting that information more frequently and within a shorter time frame. In addition to that, CMS is also proposing that the minimum data set that is required for skilled nursing facilities when patients are admitted, the assessments will now cover all individuals and not Medicare. And so all payers, information for all payers and all beneficiaries will be requested to be reported as part of the QRP. Again, an additional concern. And so if there's comments, if you're a SNF organization and you're concerned about the burden that will put on your organization, I think it's a good proposed rule to comment on. I had mentioned it previously, but noting that CMS is also seeking some feedback on advanced care planning. Again, advanced care planning has now shown up in skilled nursing facilities and as the potential for future measures as part of the QRP. They're just looking to see how ACP reporting would be meaningful to organizations, be meaningful to the SNF's QRP program and reporting of that. And so they're seeking feedback on potentially including that as a QRP in the future.
And I would think that if you are a skilled nursing facility, commenting on the change in the reporting period for the submission of your data would be a very, very important issue to comment on. So I do urge you to take a look at that. From the inpatient psychiatric facility proposed rule, I thought that we might need this after we started reading all these rules and dealing with them, but recognize that, again, comments on this particular rule are due on June 1st. If it is applicable to you, please do comment. This is going to apply to both your freestanding psychiatric facilities and your exempt units that are a part of your acute care hospital. So from a payment update perspective, we are looking at a 2.3% increase in the base rate. They are using 2021 data for this analysis. Last year, there was a 2.4% increase finalized, but this is a proposed 2.3. If there is more current data available at the time the final rule comes out, they will use that. to address the market basket and determining what the market basket is. Based upon the proposed rule, market basket was 3.1, again, less 0.8 percentage point productivity adjustment. Using the adjustment that is proposed, the per diem rate would increase to about $912. It's currently about $893. So an increase in the rate if you are not submitting your quality data, that rate would be $894 for 2027. They always publish the change in the payment rate to electroconvulsive therapy. In this particular year, they are proposing an increase to $688 from the current $673. So a moderate increase there. On the payment update provisions, they have also proposed an increase in the labor share, meaning more of your payment rate is going to be adjusted by the wage index. Currently, you're at 79% for inpatient psychiatric facilities. They are proposing to increase to 79.1. They are also asking, and I think this is very worthy of a comment, should there be an inpatient psychiatric facility specific wage index developed? Are there unique considerations that are applicable to inpatient psychiatric facilities and the staff that they employ? So recognize that this is an opportunity for you to weigh in, as should there be a wage index or a wage index tied specifically for inpatient psychiatric facilities. They are maintaining the 18% adjustment that we got last year as it relates to rural inpatient psychiatric facilities, and that their payment rates are actually increased by 18% compared to those in an urban area. Cost outliers, I think you are all aware, they are intended to limit the financial risk of unusually costly patients, so that the facility has the opportunity to get a boost in its payment if they have an extremely high cost case. In this particular year, they are proposing a decrease in the fixed loss dollar threshold or the outlier threshold. This means that more cases have the opportunity to become an outlier with this particular decrease in the rate. They are also proposing, and another area that I think is well worth comment, a cap on outlier payments at the facility level, so that although you have the fixed dollar loss threshold to qualify as an outlier, they are looking at a cap on total outliers within a facility. They are proposing 20%, essentially saying that no more than 20% of a facility's total payments, effective with cost reporting periods beginning on or after October 1 of 26, would be paid as an outlier. There is a 2% overall aggregate cap on outlier payments. That's what they use to set the threshold, but recognize that they are now proposing a cap at the facility level of no more than 20% of psychiatric payments. They have said that there is not a significant change, although overall outlier payments would be going down, but those payments that are being reduced are concentrated on a small number of actual facilities. Bryn?
Thanks, Kathy. I think it's interesting, and I think a lot of inpatient psychiatric facilities should or will be commenting, because there's a lot of changes coming for them. Not only, I know you mentioned the wage index, but the quality reporting as well is increasing kind of what they need to be reporting. So encourage the comments to come. So as far as quality reporting for inpatient psychiatric facilities, CMS is proposing that they're going to implement a new patient assessment instrument. They're going to do it in a phased approach with a simplified version to start with the intent that it would expand beyond that. So currently, the proposed expectation is that the IPF patient assessment would include essentially the standardized assessments from the 5 different categories that are typically expected to be reported on. So you would be reporting on functional status of the patient, their cognitive function and mental status, any special services or treatments that are being provided, any medical conditions that are being addressed, and any impairments that the patient may have during their time and stay. CMS is proposing that there will be quarterly data submissions beginning 10/1 of 2027, regardless of payer, and impacting the fiscal year 2029 payment determination. Again, I think it's a theme that's kind of going on throughout the proposed rule here, is that essentially CMS is saying we're not considering just Medicare as a determination for quality reporting. We're considering all patients or most payers, and typically Medicare Advantage, in the quality reporting there. The expectation essentially is that the requirement would be that there's a completion of 100% of the items that are on this patient assessment for at least 80% of the assessments submitted, to avoid a 2% point payment reduction. And so with monitoring of that, essentially Medicare is indicating that if you are not, or proposing that if you don't meet the requirement, essentially that there will be a 2% point payment reduction to your overall payment. While the assessment is applicable to right now patients that are 18 years of age and older, they are requesting comments if they should be considering this assessment for adolescents, and if they should be included in the population of patients that are reporting the assessment as well. To help with reporting of the information on the assessment, CMS is actually implementing 2 proposed options for it. The 2 proposed options are the CMS developed web-based application, which would be available to organizations at no cost. The alternative option to that is an application program interface that is well beyond my knowledge of technology, but it's interesting that they're at least offering it as options for individuals to be able to submit the patient assessment information. And then in addition to that, as with all quality measure reporting each year, CMS is proposing to remove 2 measures that they don't seem to be a great benefit to the program currently: the alcohol use brief intervention and the tobacco use treatment, provided they're seeming that the cost benefit associated with that is higher than the benefit that it is to the quality reporting program. And so they're recommending to remove those as of right now.
Let's take a look then at rehab. We've still got 2 rules left to go. We've got inpatient rehab and we've got hospice. Inpatient rehab, again, comments are due on June 1st. And I do think that there are some areas on here, particularly in my opinion, it does impact staffing. So I think there's some things that you might want to take a look at. Let's start off with the issue of dollars. The payment update, they're proposing a 2.4% increase in rates compared to the 2.6 that you received last year, or this current year. Again, based upon a market basket of 3.2, less the 0.8 percentage point productivity adjustment. If more data is available, more current information is available when they publish the final rule, then they would use that to actually measure the market basket and the overall rate. Very modest increase in the federal base rate. Currently, you're at 19,371. This would be moving to 19,881. They are also proposing a very small change in the labor-related share for application of the wage index, moving from the current level of 74.4% up to 74.5%. This will be the last year of the phase out of the rural adjustment for those inpatient rehabilitation facilities that are transitioning from rural to urban based upon changes in the CBSAs. This is the last year of that program. And just like with the psych rule, they are also proposing or requesting feedback in terms of should there be a rehab facility specific wage rate, and if so, what should be the alternative sources of wage data that would be used for that. The outlier threshold proposing to decrease from the current 10,141 down to 8689, making it easier to become an outlier claim. They are also asking for feedback. You know, you always have to be careful when they're proposing major changes to the groupings for patients. But they want to know about should there be any enhancements to the inpatient rehab facility prospective payment system. Should we have new or revised clinical categories? What should we be looking at under this program? Recognize, yes, please do comment on that if you feel it's appropriate, or if you think that there are certain clinical categories that had not been well captured with the changes in the delivery of healthcare. There are some proposals that I personally think this might be a staffing issue and an issue that needs additional clarification, particularly as it relates to admissions on weekends and holidays or surrounding holidays. But they are essentially saying that under the rule that they would require all therapies to be initiated within 36 hours of admission to the inpatient rehabilitation facility. Currently, currently that 36-hour requirement is not in existence. There is a requirement also that the current functional status of the patient be documented as at admission. This would be a part of the pre-admission screening, so that would have to be done at the time of admission. They are also proposing to revise the interdisciplinary team policy to require that the initial team meeting be completed on or before the fourth day of admission, so that it aligns with the plan of care. Again, you need to look at this from a staffing perspective and a volume of patients and the issue of holidays, weekends. And they also are proposing to clarify that additional interdisciplinary team meetings would be conducted weekly, and they are defining that as within 7 days of the last meeting. So we will be looking at the staggering of these meetings and they will be, I would think, occurring in many instances on holidays, weekends, etc. Might not be a problem, but it's something I think you need to look at from your own staffing perspective. And from a quality perspective?
From a quality perspective, you'll see some similarities in regards to the SNF quality reporting. So CMS is proposing to, again, revise the time frame for data submission from 4.5 months to actually 45 days, beginning with fiscal year 2029 for that inpatient rehab facility quality reporting program. The goal is that in shortening the data submission timeframe and reducing the lag for public reporting, basically up to 3 months, would provide more current information to consumers and families as they're trying to decide on an inpatient rehab facility for their family members, and give earlier access to that information sooner rather than later. So I know, Kathy, you mentioned about staffing and just have to consider timing of this and how it impacts your organization, and could you meet that requirement without any potential penalties. Again, CMS is looking for and requesting feedback on advanced care planning. We saw it in the inpatient prospective payment rule. We also saw it in the skilled nursing facility rule. They're looking to make sure that patients are having the conversations about their advanced care planning and making sure that it's being tracked. And so care is improved for patients overall, and their preferences for care are also being documented and captured appropriately. So I think ACP is becoming a trend within healthcare in general.
Absolutely. And one thing on that, commenting on the time frame change from 4.5 months to 45 days, look at it from your staffing perspective and the time it would take you to do this. Is if 45 days aren't enough, is it 60? Would you actually come back to CMS and give them an alternative rather than just saying, I don't like this? So something to think about in your comments. The last rule that we wanted to cover is the hospice payment rate update, because hospice is on a different payment methodology. Essentially, we're looking at the payment rates for the various categories of hospice levels of care. They are looking at a 2.4% increase, again, compared to 2.6 in the prior period. They are basing this 2.4% on the inpatient hospital market basket less productivity. Those hospices that do not report quality information, they will see a reduction in their payment rates. CMS noted that about 1/5 of hospices are non-compliant with the quality reporting requirements, and they are now going to be reporting on Care Compare, those facilities that are not reporting their quality information. I've given you on the slide the hospice payment rates for the various levels of care, whether it be routine home care based upon the number of days, the continuous home care, the inpatient respite care, or general inpatient care. You've got the rates that are being proposed for those adjustments. They are proposing to a slight increase in the hospice cap. This is the maximum dollar amount, average payment amount for a hospice over the course of the year. It doesn't max out on an individual. It just addresses the overall dollar amount going to the hospice. And just like with rehab and psych, they are asking, should we have a hospice-specific wage index? But the provision that they throw in here is not, and what should it be based on, but should we use Bureau of Labor Statistics data to actually set that wage index moving forward? There have been parties that have suggested that BLS data be used for all prospective payment systems and other payment classifications for adjusting hospital wage rates. But this is the first time that I have actually seen them come out and on a program move forward with BLS or propose to move forward. They are proposing some changes to the hospice election statement regulations. There would be an addendum that would be mandatory for all Medicare beneficiaries at the time that they elect the hospice for care. And that addendum would explain what conditions, items, services, drugs the hospital has determined are not related to the beneficiary's terminal illness and related conditions, and therefore not covered under the hospice benefit. So you might have a particular drug that is given for another condition that perhaps relieves pain for a patient, but it is not tied to the condition that they are in hospice for, the terminal condition. And so this is a question of, will the cost for that care be a part of the hospice benefit, or will it be paid for in a different manner? They are also proposing to allow a physician designee and the physician member of the interdisciplinary group, in addition to the hospice medical director, to discharge a patient from hospice care. So this expands the roles of those other individuals to allow them to also actually complete the discharge. And they are making the provisions related to telehealth in the face-to-face policy consistent with what was passed earlier this year in February as it related to the Consolidated Appropriations Act of 2026.
Kathy, I wonder how a hospice center is going to operationalize identifying the medications that are not relevant to the hospice care. Like, how do they divide that, and how do you make sure that, excuse me, you operationalize that so your staff understands what they're doing?
Well, I agree wholeheartedly, because this was an issue. Those of y'all who know me know that I follow the Medicare Payment Advisory Commission, MedPAC, on a regular basis. And this is an issue that they have raised and that they are looking at in terms of those particular drugs, perhaps, that ease pain for the individual, but it is not pain tied to the condition for which they are in hospice. Will they continue to be able to receive that medication? So very concerning in terms of where this goes. And it's identifying those drugs and what is actually tied to the condition versus other issues that the individual might have. So it's going to be interesting in terms of how it goes. Interesting to see how it works.
So as far as hospice oversight is concerned, CMS has developed a new measure and they're calling it the Service and Spending Variation Index. And basically it's a scoring methodology for hospice centers. The goal is what CMS is trying to do based on the proposed rule is to be able to identify any potential risk a hospice organization has. And so they're seeking feedback on the index, on the scoring methodology. Does it work? Does it not work? Is there a different method that would be better? The intent and the goal is that the new scoring system would essentially rank hospices on indicators such as inappropriate utilization, quality issues, compliance issues, looking at the percentage of patients that are discharged and then they return to hospice, they're discharged live, and then they return to hospice. They're kind of scoring them on all of that information. The scoring of the different facilities would actually be posted to the CMS site on the CMS Hospice Center page. And so there'd be a listing of every hospice organization, what their score is. Essentially, a hospice organization would be looking to have a lower score because facilities with a high-end score would be subject to additional reviews by CMS to assess if there's risk within their program, if there's potential compliance issues or concerns. And so if you are a hospice organization and you are interested to know how this scoring methodology is going to be utilized, what they're looking at, how they're going to score your organization, it's important to comment on it and make sure that it's a doable it's a doable scoring program, and it's not creating additional operational issues within your organization as well. And with that, we are towards the end of our presentation. I think we have covered many different areas that require commenting, especially with reducing the amount of time for quality reporting within SNF, within inpatient rehab, looking at the hospice organizations and the new scoring methodology they're going to be utilizing. So if you're any of those organizations, I encourage you to comment on those and see how they impact your organization and what it would mean for you from an operational perspective if these changes were to be in effect.
And at the same time, look at the dollars. Look at how the dollars are going to impact your facility. You're being asked to do more for not a whole lot less, or for not a whole lot more. You're being asked to do more for if dollars that we don't know are really keeping pace with inflation and the cost of labor and supplies. So please do take a look at the impact of these rules on your organization and comment. You can go to the website that is listed here and find all of the proposed rules that we've discussed. So with that, shall we turn it back to Jennifer?
Thanks to our presenters, Kathy and Corinne. Also, the slides and recordings for every episode of PYA's Healthcare Regulatory Roundup series are available in the Thought Leadership section of PYA's website, pyapc.com. While at our website, you may register for other PYA webinars and learn more about the full range of services offered by PYA. On behalf of PYA, thank you for joining us. Have a great rest of your day.